Thank you so much for inviting me to talk to you today. I'm going to talk about the revolution of diagnostics in clinical microbiology that has enabled us to go from answers in days to answers in minutes. And I've divided my presentation up into 4 areas: proteomics, imaging, metabolomics, and genomics. What I'd like to do is highlight some of what has happened recently, and then also transition to what is happening and what can happen in the future with rapid diagnostics. I chose to start with proteomics because I think this is a really great example of an advance in technology that has made a huge difference in patient care in terms of microbial diagnostics. We've seen huge changes over time, and most of these changes are technology changes that have nothing to do with microbiology, but that have been taken from technology advances and brought to the microbiology laboratory. The concept of using mass spectrometry for bacterial identification was suggested back in 1975 by Catherine Fenslow and John Anhalt, but they didn't really have a way of operationalizing it. It wasn't until the mid-1980s that MALDI-TOF mass spectrometry was described. But even then, it was not really possible to use this technology to identify bacteria. And I'm going to show you why, because it took not just the technology, but something else in order to make this possible. However, by the year 2008, the concept that you could use MALDI-TOF mass spectrometry to identify bacteria in the clinical context was shown to be possible. And after that, there was a huge acceleration to adoption in clinical microbiology labs in just the year or 2 or 3 that followed, and ultimately in the approval by the United States FDA and other regulatory bodies of this technology for bacterial and fungal identification ultimately. And this has completely changed the way that we do things. And so this technology has changed what took us days to do to just minutes, literally a handful of minutes. And it's a technology for identification of bacteria or fungi that are grown as colonies on plates, where in the past we had to do a lot of sophisticated biochemical testing, a little bit of which was rapid and would take, just a few minutes, but most of which would take a fairly long time overnight and sometimes days to yield results. And plus, we had to do panels of biochemical testing. With this technology, it's one identification strategy for all types of microorganisms. And it's really easy to use, as you can see here, just taking the colony, putting it down on a mass spectrometry plate, and then overlaying it with some chemicals and putting it in a machine and getting your answer in just a matter of minutes. This technology came to be because of the development of MALDI-TOF mass spectrometry in the 1980s, where there's a matrix that embeds your analytes of interest so they don't get fragmented when they get hit by a laser. But importantly, it took a lot longer before this got adopted into microbiology laboratories. After the analytes of interest these are ionized, they are separated based on size in a time of flight analysis where they travel to a detector and then yield a mass spectrum. And that's where the other part of this comes into play. It's not just MALDI-TOF mass spectrometry. It's really also having a very good database of mass spectra, and that's important for any identification system. And also, importantly, the analytics software that can take those mass spectra, run them against a database, and compare and give a rank order of what that identification might be with sort of a probability of that being the correct answer. So this took a while for this to happen because, back in the 80s, we didn't have this kind of software that we could avail ourselves of. So this has made a huge difference in clinical practice and is now standard of care in many laboratories across the world. But what also is the situation, if I reflect on this, is that if we go back to, say, the early 2000s, maybe 2005, 2006. If you were to ask a clinical microbiologist if we'd be using proteomics to identify bacteria routinely in the clinical microbiology laboratory, I'm pretty sure that most people would have been a little dubious that this would become the standard so quickly. And I find that very exciting because, you know, most of the developments that we're seeing in our field are a matter of taking technology and then applying it to the needs that we have in clinical practice, in clinical microbiology, and bringing forth new diagnostics that way. And it means that there may be new technology developments and new applications. And I think that's what you're going to see with the next few categories of advances. So the next one I want to go to is cell imaging. There's a huge revolution going on in digital imaging, image capture, image analysis that's happening in pathology, but that's also being applied in the domain of microbiology. And this is just one example. I think that with time, you're going to see many more examples. This is an example of a platform that does rapid antimicrobial susceptibility testing. It's been developed specifically for positive blood culture bottle testing, although conceivably it could be used for other applications as well. And this is a platform that happens to be from Accelerate, called the Pheno system. So what it does is it takes the contents of the blood culture bottle and it cleans them up to take the bacteria out using electrofiltration and immobilization. And then it goes through an identification step using fish probes. And then finally, antimicrobial susceptibility testing by real-time imaging of bacteria growing with and without antibiotics and comparing those profiles. So I'll show you a little bit about what happens inside the machine. I think the other big advance with multi-top mass spectrometry or this technology or some of the other technologies that I'm going to show you is that they're not really configured as, say, a research lab type of application. They're really locked down into a system that's very easy to use. And that's what's needed to realize the benefit of rapid diagnostics. So within this system, there's a gel electrofiltration that separates out bacteria from the content of the blood culture bottle that might include various assorted chemicals and proteins and so forth, but also separates out the bacteria from blood that came from the human. And then the bacteria are electrokinetically concentrated. And then after identification using fish probes, they're placed in individual wells and they're exposed to various concentrations of numerous antibiotics and watched in real time to see what happens. So here with this time-lapse dark field imaging, what you see on the bottom is a drug-resistant colony because in the presence of, in this case, 4 micrograms per milliliter of piperacillin tazobactam with this E. coli, you see the organism growing up into a colony. But on the top, you see that it's forming these long filamentous type of forms, meaning that it's susceptible to the antibiotic. So all of this then has to be captured by a camera and then interpreted into susceptible or resistant to provide a report that recapitulates what you would get with regular susceptibility testing on one of the automated platforms like Phoenix and Vitech, Microscan, and so forth. And this works. This is cleared by the United States Food and Drug Administration. And within several hours, you have your rapid susceptibility result. And I think we're going to see a lot of other advances like this in imaging use in microbiology. It's just the beginning of what is possible. Another area that I think is an interesting technology advance is that of metabolomics. You know, you're familiar with volatiles that are given off by microorganisms that can be sensed. For example, you know, we used to use gas liquid chromatography a long time ago. That is in no way, shape, or form an easy-to-use technology, and we abandoned it actually with multi-top mass spectrometry coming into the laboratory. But you also know that certain organisms have like characteristic odors like Pseudomonas aeruginosa and that fruity odor that you smell and so forth. So using what's given off the metabolome of the organism and sensing that is another way to detect microbial growth and potentially to identify organisms as well. And while there isn't an FDA-cleared platform that uses this per se for clinical microbiology applications, this is under development. And here's a platform, for example, from Specific Technologies that uses metabolomics to sense growth of microorganisms and has been configured in a way to report out antimicrobial susceptibilities. So what's done here is there's a 96 well plate format, and over each well there's a sensor that senses the various metabolites given off by the organism and is an indicator of growth or no growth of the particular organism. And then in each well, you have various different concentrations of antibiotics, and this can be configured to deliver susceptibility results. This technology is not yet available for routine use in the US, but is under development and, hopefully will become something in the future. So using metabolomics, I think, is another way of getting to a rapid identification. And then finally, sort of the biggest area in the field is that of genomics and using microbial DNA or RNA to execute a rapid diagnosis. This is the area where there's been perhaps the most activity over the past 30 plus years. And it's interesting to reflect back on what's happened, what's happening, and what can happen in this area. So if we take a look at sort of a timeline here, DNA is described in 1953, PCR is described in 1983 by Carey Mullis. And as soon as that happened, that first of the nucleic acid amplification technologies is really a major advance that it gets leveraged into microbial diagnostics. In our own lab, we started offering microbial PCR assays clinically in 1991. So not that long after that technology advance came to be. But back in those days, this was really a clumsy way of doing things because we did a PCR, and then we had to run out a gel and see our band. And then for specificity, we did a Southern blot analysis. And so it wasn't rapid, and it certainly wasn't all that easy to execute in the laboratory. But then what the next advance around the turn of the century was the advance of real-time PCR. Real-time PCR enabled several advances. One, it was all done in one tube. So there wasn't any post-processing testing that was needed, and that's faster, easier to do, but also mitigates a risk of contamination that, of course, comes with PCR. And in the early days of PCR, there was lots of concern about contamination. There still is. It's something that people who do PCR think about all the time in terms of quality control, but this really helped mitigate some of that concern. And real-time PCR, I think, was a step towards very rapid diagnostics that has been now delivered in even better ways. So one of the advances that happened was to be able to offer multiplex PCR, so not looking for just one thing at a time, but multiple or organisms or resistance genes, DNA or RNA of any type, really, all at the same time. And then more recently, in the past 7-8 years, we've seen rapid nucleic acid amplification tests. And of course, with SARS-CoV-2, this has been just, the perfect time to be able to deliver and offer a lot of new diagnostics. So this is a slide that shows the real-time PCR assays that have been developed and are offered or have been offered. Some of them have been replaced by commercial assays over time at my institution, Mayo Clinic. And it's just interesting to look back on this and reflect about it. For some of these, it was really a matter of offering a truly new way of making a diagnosis. And that example is herpes simplex virus. Prior to the availability of PCR, we had to take many patients to brain biopsy to make that diagnosis. There was no other way, but PCR and spinal fluid really revolutionized that diagnostic approach. And there are many other examples of that. Some of these, however, we had diagnostics for. They were just very slow. And so having a PCR-based approach, especially a real-time PCR-based approach, gave us the possibility of making that truly rapid diagnosis. So it's a combination of both speed, but also just really changing the field. And I'm going to come back to that later on with my vision kind of for the future of using some of these nucleic acid amplification techniques. There was also the concept of doing multiplex PCR. That is looking for more than one thing at the same time. The classic idea, of course, with PCR is you're going after one target, but it doesn't have to be that way. And we know in infectious diseases that there's oftentimes a differential diagnosis. Culture, for example, is really somewhat of an agnostic technology that can look for lots of different types of organisms at the same time. And in many cases, that's really needed for clinical diagnostics. So configuring multiplex assays has been a huge advance as well. I know they're not without controversy about what exactly should be configured together, but I think one example that has been very useful for us is to think about the concept of multiplex PCR or panel PCR for gastrointestinal pathogens. And today we have in the US multiple panels that detect gastrointestinal pathogens, including bacteria, viruses, and parasites as well in some cases. And these really, in my mind, are state-of-the-art types of diagnostics where you need to use a diagnostic for gastrointestinal pathogens. They clearly enable us to find more pathogens than we were finding before. This is an older study that we did at our institution where we looked at the frequency of finding a gastrointestinal pathogen with what clinicians were routinely ordering versus what you would find with a large multiplex panel, in this case, the BioFire panel. And with routine ordering, a GI pathogen was found in 8% of cases, whereas with a multiplex panel was found in 33% of cases. And mixed infections were found in 8 and 21% of cases, respectively. And importantly, to the tune of this presentation, this is a very rapid test. It is executed in an hour or so. Whereas if you're going to do individual assays for many of these organisms, it can take you days to get to your answer, especially for culture-based diagnostics. So one of the controversies that comes up with novel diagnostics that cost more is when exactly should they be used? Multi-top mass spectrometry, which is the technology I began the presentation with, is wonderful because it's faster, it's actually better. I didn't spend a lot of time talking about that, but it's enabled us to identify organisms we couldn't identify before, which is pretty exciting. But it's also less expensive than what came before. Most new technology, however, is not less expensive. In fact, most of it's more expensive. And that's a case in point with these multiplex gastrointestinal panels. How to use our tests correctly, regardless of cost. And so for gastrointestinal testing for acute gastroenteritis, what we recommend at Mayo Clinic is that if your patient has community-acquired diarrhea of less than 7 days duration without any warning signs of fever, bloody diarrhea, dysentery, severe abdominal pain, hospitalization, dehydration, or an immunocompromised state, that they actually need no testing. But if they do warrant testing, for example, by having community diarrhea of 7 or more days, travel-related diarrhea, or any of those warning signs that I listed, then that's where testing with a multiplex panel makes sense, unless, of course, it's just C. diff that's under consideration, in which case specific testing for C. diff makes sense. So we really have to think about how to use these tests. Another example is the BioFire film array meningitis encephalitis panel. I list this because there's only one available in the US, one company's test. This test looks for 7 viruses, 6 bacteria, and Cryptococcus neoformans gattii. And it really goes after some organisms that we already use nucleic acid amplification tests for, but sort of adds out in the portfolio. This is created some questions about when to use this as well and what does it replace, because it really doesn't replace much of anything short of maybe some of the viral PCR assays on the left-hand side. Still need to do your spinal fluid, gram stain, protein glucose, culture, cryptococcal antigen testing, because this test happens to be somewhat less sensitive than cryptococcal antigen testing. So if that's a possible differential diagnosis, that needs to be assessed for separately. So, you know, it can play a role, but it's maybe a little bit more limited in terms of where it fits in. It's not a true replacement technology. And then we've had a true explosion in testing for blood culture bottles. I talked about the Accelerate Pheno in terms of imaging. These are genomic tests that will look for a whole number of different bacterial species now. You probably can't read this because the list has gotten so long, both gram-positive and gram-negative bacteria, but also yeast and some fungi, as well as resistance genes to really tell us rapidly what's going on in those positive blood culture bottles. And like I said, these have expanded over time, which is, I think, very exciting. The numbers of organisms that can be looked for or targets in a single test is truly amazing. And many of these are very rapid, delivering results in, say, an hour. Whereas, you know, in the past, to get to some of these diagnoses would have taken us at least another day, if not even longer than that. So, you know, true advances in rapid diagnostics. The other area where this is really advancing is in the type of PCR that's really just very rapid and configured for point of care type of use, where you can get your answer, you know, in 20 minutes or so. It depends on a particular application. And there are many now platforms we have to do this, especially with the explosion of testing around COVID-19. But just to show you a couple of examples, this is the Roche Cobas-Liat platform that uses organism-specific PCR configured to detect SARS-CoV-2 with or without influenza, Clostridioides difficile, Streptococcus pyogenes, and that's really very easy and quick to use. If you're doing a swab-based test, the swab is collected, placed in liquid media. That liquid media is pipetted into this container. It's barcode scanned and then put into the instrument to rapidly deliver a result. And this can be deployed in a whole number of settings. And likewise, Cepheid's Expert Express platform is another kind of point of care type of platform that can test for influenza and RSV, just influenza, Streptococcus pyogenes, and SARS-CoV-2, influenza, and RSV, and delivers results very quickly in 18 to 36 minutes or so, depending on the particular analyte that's being tested for. And we're seeing examples of this kind of testing being done in a number of different settings. Obviously, we have in-home testing with nucleic acid amplification tests now possible as well today. So just huge advances in testing, amazing considering, you know, what has happened over time. But I think we also need to realize that this is taking technology and applying it to do what we need to do in medicine. And we really need to think about what's possible and what the important questions are that need to be addressed. And sometimes there's the obvious, you know, I've been doing this for years, I just want to do it faster with a rapid nucleic acid amplification test, but sometimes we really need to think outside the box about doing things differently. So I want to end with this example, which is the example of Helicobacter pylori. This is an organism that we've known about for several decades. We treat with antibiotic combinations, but we have very little insight into its resistance profile. We know, based on some work that we've done, that clarithromycin resistance rates and honestly resistance rates to metronidazole and fluoroquinolones as well are pretty high when we look at isolates from stomach biopsies. But most patients don't undergo that kind of testing, and they're just treated empirically for this kind of organism. So recently, we developed a PCR assay to be done on stool that looks for the organism, but also looks for the SNPs that are associated with resistance to clarithromycin and provides very good accuracy in terms of prediction of that resistance. And this is, I'm not going to go over the whole study, but we showed that compared to fecal antigen testing, fecal testing with this PCR assay had very good accuracy, a sensitivity of 89%, and a specificity of 97%. So the idea is really to take stool specimens and be able to diagnose H. pylori, but also to diagnose resistance to clarithromycin and maybe in the future other antibiotics as well. And what we found in our PCR positive stool samples is that the rate of clarithromycin resistance is generally in our practice around 30% or a little bit more. So it's not insignificant, but we really haven't known much about this. And when we looked at outcomes, we looked back over our cases. If there was predicted clarithromycin resistance, the chance of treatment failure was very high. The success rate overall was 48% when clarithromycin resistance was predicted versus 74% when no resistance was predicted. And for patients receiving clarithromycin-based triple therapy, the success rate was only 41% when there was clarithromycin resistance predicted versus 70% when no resistance was predicted. So I think we really need to think differently about not just diagnosing an infectious disease, but really providing information about how to treat it properly, especially given the challenges that we will find ourselves in, do find ourselves in the context of antimicrobial resistance. So I want to conclude here. I've shared that proteomics have been a huge advance in rapid diagnostics and that are now standard for bacterial and fungal identification, that imaging advances are now being used to assess antimicrobial resistance and will be used more in the future, that there's preliminary development of microbial metabolomics to assess antimicrobial resistance and potentially for other applications in the future, and that nucleic acid amplification tests have really made a huge difference in rapid diagnostics, both for microbial detection and, as I shared with Helicobacter pylori, potentially to be leveraged for prediction of antimicrobial resistance or antimicrobial susceptibility. With that, I'd like to thank my teams at Mayo Clinic, both my research laboratory team and the clinical laboratory team who executes these tests, and the NIH for supporting this work. Thank you so much.
Hi, good evening, Prof. Patel.
Hi, good evening. Can you hear me okay?
Yes, we hear you very well. Thank you for joining us today despite the very different time zones we are in right now.
No problem. I'm happy to be here.
We are very unfortunate that we have only perhaps time for only one question, though we would love to have more time. This question comes from one of the participants. In terms of lab stewardship, what do you do in your hospital to ensure that such expensive rapid tests such as accelerate phenols or the rapid net tests are not being used in a useful way and not being
yeah.
Do you employ an algorithm-based system?
This is a really good question. I showed an example of a diagnostic algorithm for using the GI panel. And anytime we introduce new technology, we really ask the question of under which conditions would you use this new technology? In which patient population? And would you use it as a first-line test or as a second-line test when you don't get an answer? And so I'm a really big fan of algorithms, because they help us think that through, and they're hard to set. If you set algorithms with your clinical partners, you can spend a long time figuring out what you might want to do, but it's really important, because then you can use that to make sure that people who need the test get it, which wasn't the question that was asked, but also that people that don't need the test, if it's an expensive test and it's not going to be helpful, don't get that test. And you can build that into your electronic medical record. You can build a system to make sure that test ordering happens properly. But you have to know what you want and what the right thing is to do. So I'm a really big fan of test algorithms like the one I showed you with the GI panel.
Thank you very much. Despite we're running short of time, perhaps can I ask one more question? Do you employ rapid NET in your hospital as a form of point of care test? And if you do, are there some challenges that you have encountered before, and how do you go around solving them?
Yes, we do employ some point of care NAT tests, but we also have a system within Mayo Clinic where we rapidly receive specimens. We have a pneumatic tube system that gets specimens from the hospital to the laboratory at 60 miles an hour, like 100 kilometers an hour. And it's about a mile away, so it comes to us really, really quickly. So we centralize a lot of our testing, and we make sure that we prioritize certain tests ahead of others so that we can offer rapid diagnostics using some of these point of care technologies in the clinical laboratory, which means we don't have to have a point of care test, you know, on every single ward. But there are some of them that we offer close to the patient, especially for the emergency department. So we have that right there for rapid diagnostic testing. So I think you really have to think about your system, what makes sense, where it makes sense to do these tests, because you have to have, you know, people that are able to run them. And, you know, even though they're easy to do, and in the context of the US CLIA wave, so you don't need to be a laboratorian necessarily to run them, you still have to have people who are able to run them and get them reported out. So you have to think about where it makes sense to use them in your clinical practice.
Okay, thank you so much for joining us today, and you have a safe journey.